So guys, welcome to the Beyond Coaching Podcast. With me here, I have Max, and then I have this guy that just showed up, Quinn Henoch.
It's a nice place.
Yeah.
Yeah, you know, Max sleeps here, actually.
Yeah, this brick wall we had installed a few hours ago, it's pretty nice.
If you have an extra room,
Yeah,
let's talk.
There's room on the couch. You could snuggle up.
Okay.
It's
like old times.
Yeah, head to toe. Head to toe, that's the only safe way for that to happen.
So this episode is going to be informative, but probably more comedic, with some more information as well. So, you know, we'll see where this goes. I have some topics I want to ask you, Quinn. But Quinn, let's start off with introduce yourself. Tell the people, you know, what you do, what Clinical Athlete is, and all that good stuff.
Yeah, sure. So I'm a physical therapist here in Southern California. I do a little bit still in person, mostly work in the digital health space, and that's kind of what Clinical Athlete is. So we work to mentor and educate clinicians, soon-to-be clinicians, in the realm of exercise prescription, because you would think in the PT space you would get a lot of that,
Right.
But you don't really get that much because there's a lot more to a physical therapist than just the athletic space, but that's kind of where we specialize. So these PTs coming out of school, trained to be generalists, don't actually know how to work with athletes unless they had prior S&C background. So we take them under our wing and mentor them and educate them on that, and then their clinics as well.
And you guys are nationwide or worldwide?
I'd like to say we're worldwide. I mean,
Oh,
we
wow.
do
Mr.
have
Worldwide.
people in different countries. So
You could say it.
international,
Yeah, worldwide,
technically
international.
Wow.
Clinical Athlete International. So we've all met, I mean, same period of
Yeah.
time, what, 2015, 2016?
Yeah.
We all used to work at Juggernaut together.
Yeah.
You know, Quinn, how long have you been, when did you start doing physical therapy, and when did you start your own physical therapy business even?
So I graduated from PT school in 2013.
Okay.
And I started actually doing my own thing right away, which I don't recommend because we also don't get any business training in PT school whatsoever. But luckily I also worked part-time at a clinic and they were cool with what I was doing. So for about a year and a half, I worked in a regular kind of traditional clinic, started my own practice inside of a CrossFit gym right away, day one. And then we moved from that CrossFit gym to a mixed martial arts gym, and I saw kind of anybody and everybody. And then that was about a year and a half after school, and then I moved to California. I competed at the Arnold Classic, packed up my little Honda Civic, and drove out to
Yeah.
California, and I've been here ever since.
Did you win the Arnold?
I'd like to say I won the Arnold in my own special way.
I win in my own special way all the time. That's what Max tells me.
Well,
at
we're
least.
all winners here. We're all winners. When you left to come here, did you have anything set up, or were you just like, I'm just going to figure it out?
It was more of that.
Yeah.
Well, because I think the opportunity wasn't set up yet.
Yeah.
You know, so
We all know how that was.
yeah, no, I mean, but I was excited. Like, I knew that was going to be the case, and I was fine with that.
Yeah.
I thought just moving out to California, even just as a kind of a minimum, would
Right.
be cool to experience.
Right.
And then
So you did.
things change, but I found other opportunities. And
Nice.
yeah.
You know, it's funny. So, like, on this podcast, a lot of people that listen to this, we talk about business a lot, you know, because it's a lot of coaches looking how to grow their businesses. You know, podcast is sponsored by Coach Logic. Max just so happens to own Coach Logic. I don't know how that happened, you know, but we've got some bias here.
Lucked out.
And the main reason we invited you on is because you didn't sign up right away. So we actually want to invite you on the podcast to sell you.
We're just going to bully you into it.
I'm a
right
hard
now.
sell.
Yeah.
But the business side, you know, we have never talked really about the business of physical therapy and like cash basis versus insurance and stuff like that. I mean, out of curiosity, like you mentioned, you wouldn't have started your own thing right away. Like, I'm just wondering why.
Well, I did start my own thing right away.
Oh, but you're doing both. But you wouldn't have. You wouldn't have recommended that. My bad.
Correct. Well, simply because I didn't know what the heck I was doing. I mean, coming out of school, you, in my opinion, should be worried about being a good physical therapist or being good at your craft, honing your craft, getting the reps in, not having to worry about, also keeping the lights on. Because as soon as that dichotomy happens in your brain, like, I have to make money, the professional development kind of goes away because it's opportunity cost. You only have so much time. So am I gonna learn how to be a better physical therapist? Am I gonna spend my time there where the return is not immediate? Or am I gonna work on my marketing campaigns and to keep the lights on? So that's prior to actually honing your skills. So I think that it halts your progress, and you're not gonna have a good business if you're not good at what you do.
Do you think there's a timeline you would suggest? Like, say someone's new to, PT, they get out of school, you'd say like, hey, work this long, then start a business, or?
Well, you can start. So what I would say is kind of what I did. I'll give myself credit in this regard, is I didn't make it my sole thing right away. So you can start dipping your toe in the water right away, as long as you're not under pressure for that to be what keeps the lights on. Then you're not biased to put all your eggs in that basket.
Right.
So you can start that right away. Find a place on the side, make sure that you didn't sign some type of disclosure form with the clinic that you work at where they were like, we don't want you to do that. I was very upfront. They weren't worried about me. I was just a little office across town. But I think you can start right away, but just have stability somewhere else so that you can learn without the pressure.
Right.
And you asked the timeline very arbitrarily. It seems like people have the best luck that like 3-ish years out of school, when they've really gotten a lot of reps in their craft. They've potentially even moved jobs and gotten to experience different settings. And then they have a sense of the profession. They have a sense of actually how they want to practice. And I think from there, you can kind of build the business side of things.
I found it interesting. Well, one is like you have an interesting perspective because not only have you been a clinician for a long time, but you've also been a coach for a long time. I mean, the two, I think, actually go hand in hand. And that's one of the topics I want to talk about today. But it sounds like with physical therapy business, I mean, it sounds like similar as coaching business, where it's like maybe it's good to go coach in person at a gym for some time, build your experience as a coach, and then maybe take that online or then go do your own thing once you've become a better coach.
Yeah.
So I think there's a lot of similarities there. What have you seen? So like one of the things that I've always wondered about is like the relationship between like rehab and performance. So obviously, when we're talking with barbell sports, athletes are in peaks, they get in, snags, they're getting pains. What are some things that you've seen that athletes or coaches could be doing to help their athletes avoid, getting injured in those peaks, or things that they can help them with so they don't have to maybe go to the clinician quite yet?
Yeah. I've made it my job to make people not need my services. I'm probably not a great business model, but I mean, I think the coaches serve such an important role because you guys are the first line of defense. And I, to your point, my background was in strength and conditioning before PT school. So I think the first thing is reframing what rehab and versus performance is, because it's not this dichotomy. It works on a continuum. I mean, the exercises are largely the same. The inputs just have to change a little bit for you to manage whatever you have going on. And I think that alone is important because people think, I'm going to do my rehab. I'm going to do my rehab exercises. Yeah. And the idea is that because it's a PT that gave you this glute bridge, that it has some magic healing power. Yes. And it just doesn't. Yeah. And so you have to think of it all, forget the labels. It's all load and stress and mechanics. And then we have to kind of fine tune the dose and find the entry points that you can still get some training stimulus in. So I think what coaches and clinicians can start with is, okay, we know a needs analysis. We know their desired activities. If it's barbell, it's easy. It's just the competition lifts at the pinnacle of that. And then in the same way that we would do for training, where we want to train certain qualities with supplemental or accessories, we now have to find new entry points if some of those movements are off the board right now. So go back to your coaching roots. And if you're a clinician, think about training in terms of a dashboard and all of the variables that you can manipulate and turn the dials up or down. And it's a lot of times not, okay, we can't do this for a while, or you should do something else, find a new hobby. It's, okay, we can find another variation. We can find another dose of intensity or volume or range of motion. While biology does its thing, like the body is going to heal, this thing is going to calm down. In the meantime, though, we're mitigating fitness loss. And so it's finding a middle ground between all or nothing. And that's the biggest mistake I think people make across the board, is they're not training the way they want to, and so they dial it way back and they just dig themselves into a deeper hole.
Yeah, it's almost like you get into this situation where as an athlete, like you have pain or something, my knee hurts, so you back off squatting, and then
completely
maybe none. Yeah, you don't squat at all. And then like your knee kind of still hurts. So then like you try to start squatting again, but then it hurts more. And then that load you can use just starts to come down even more. So it's like you almost just like lose all ability to train. And then you basically look at it as like, well, my knees just hurt now. And you might just give up on it or like try to, find something else.
Well, and you were an extreme example because you had
example, barely has knees.
Yeah, but that exact thing is it's actually termed in systems science the drift into low performance. So it's actually a thing.
It's a thing.
It's a positive feedback loop in the wrong direction. So positive doesn't mean good or bad. Positive means it's a reinforcing loop. You do less, you become deconditioned, therefore you handle less. That load hurts. You do less. You become
Is there a
deconditioned.
name for it? The Henoch principle?
Well, we call it in ClinicalAthlete the drift into rehab purgatory.
The drift.
So you're just staying on this downward decline.
Right. Yeah.
And then to your point, the person starts to almost identify with their injury, and then it becomes
Yeah.
really hard.
As a name.
Yeah.
Yeah.
It's the knee.
Old Gertrude
the old
there.
back.
Yeah.
And so like I deal with this all the time with SoCal powerlifting. So we have those clients who you find you have like your competitive clients that they'll do anything to train around the injury, and we'll try to we'll adjust volume, load, tempo, a range of motion. Like there's so many variables to adjust to ensure that they can perform and maintain their fitness. But then you have the client who's like goes to the local physical therapist in the corner that says stop what you're doing immediately, or worse, their ortho. Stop what you're doing immediately. If it's an ortho, they're like, I want to open that thing up and take a look. How can, for the coaches that are listening to this, how do you have that conversation? We're not doctors, you are, but how can they have that conversation with a client that just wants to stop immediately because the doctor just spooked them?
I think part of it is making it has to be a dialogue. So you can't, like the mistake I've made in the past is I hear this scenario of the doc and I get like, ooh, I start getting pumped. Oh no, and like this person, maybe they actually have a relationship with that other clinician, and I'm over here just, beating that idea down. And so now this person's confused and stuck in the middle, and that's a really good recipe for that person to just kind of wall up and not listen.
Yeah.
So I think the first thing is you've got to ask questions, and like the direction that you want this conversation to go, but they've almost kind of have to realize it themselves. So people are generally reasonable, but they have to be reminded of the same thing over and over. So forget injury for a second. Just think of athletes. Like every athlete, hard charging athlete even, they know they're not going to set PRs every day, every time they come to the gym.
Unless they're 16 years old.
Unless they're 16. Unless they're a newbie in something. And at some point that's going to stop. And they know that intuitively. Like if you ask them, I'm like, do you think you're going to set a PR every day for the rest of your life? Like, of course not. But what happens when they have a crappy day in the gym? Their life is over. Yeah. So it's the same thing. It's just manifested tenfold because now the turnaround is not as quick, but it's the same conversation. So I'll actually pull it back to performance and use that exact example to say now, okay, here's what I think is happening. We talk about this kind of cycle that they've been on, and it describes usually exactly what they've experienced. And like, is that kind of what we have going on? And get them to kind of agree to what's been happening, and then make that connection to, okay, this isn't going to be an on-off thing. It's not going to happen overnight, especially with people who have been dealing with stuff for a while. Yeah. And so just like training, we have to regain positive momentum over time, and it's going to look very gradual. And it's like a little kid who grows 3 inches in 6 months. They don't feel that growth, but it's like a big change. Right. It's the same thing with rehab. So as the coach clinician, you have to be okay with reiterating those points over and over, like it's the first time you said it, because they're going to be like, oh yeah, okay, it makes perfect sense. I'm excited. Thank you. 2 weeks later, they have a little mini flare up, and then it's like, oh my God, okay, I don't know what to do. Like, what should we do? And it's like, no, this is the same thing. This is exactly what we talked about.
So it's not a straight line. It's very jagged.
It's very jagged. And training's like that too, though. We know that. It's just a little bit, in rehab, tends to be a little bit more volatile, slightly more unpredictable, maybe more jagged. But if you zoom out far enough, you do see the overall trend is in the right direction. And that's what you have to point them back to. Right. And if you've got some KPIs, key performance indicators, it can be very simple. Whatever lifts they're doing, hey, we're lifting, it's like RPE and load. So you lift the same weight at now at a lower RPE, or lifting a heavy weight at the same RPE. Can be the same with symptoms. Lifting the same weight and now your symptoms are down. That's cool. Lifting a heavier weight but you're not getting worse. It's actually a sign of progress as well. So all these little things you can point back to, but I think the biggest thing is being okay with having the conversation over and over and over, and being patient with that, and then the person will start to almost answer their own questions over time. Like
do you find that there's like a sales component to what you have to do, as far as like, because I know like the whole like drift idea. I talked to you about that years ago when we, and I remember that being such a like impactful thing, because then you start to realize like, oh, I get what the problem is fundamentally. You just stop doing this. It's not like don't squat and then do this exercise and that fixes your problem and now the problem is gone, right, and then start squatting. It's just adjust your training to start, accommodating to what you need. Do you feel like that sales process is like something that is a skill you have to pick up as a PT, or you suggest, or is it like more just like hopefully it works when you kind of, this is what you have to say?
No, you're selling all the time.
Yeah.
Like those conversations, you are selling. It's just not, you're not making it.
Yeah.
You're selling something
closing
different.
at the end, right?
You're selling trust.
Yeah.
And you're selling buy-in, and you're selling their commitment to actually be part of the plan.
How do you do that? Like, let's say someone comes in and they're, they're probably super frustrated because they're maybe like have been dealing with some problems, a knee that always hurts. Maybe they're at the point even where they've given it a name, or it's like it's a thing that's part of their personality. Like,
yeah.
how do you approach that? Like, is it just a one-off thing, or do you have a strategy? Or
definitely not one-off. That first conversation is usually just the start.
Yeah.
Sometimes there's light bulb moments. Like a lot of times there's light bulb moments. Like just kind of the same thing that we just discussed. They start to be like, okay. A lot of times it'll be like, okay, so I'm just maybe like doing too much over and over, doing too much too soon, or like we can just adjust the training. I'm like, yeah, like that's where we can start. Now it's not going to be it's simple and sound,
yeah,
and in face value, but that process is going to be kind of iterative, and there's going to be some ups and downs. But I also actually find what sells the best has been to simplify things for people, and for people to understand that they don't have to try to fix everything all at once.
Right.
And I've found less luck with somebody comes in with one issue or two issues that they're dealing with. They walk out the door with 67 new problems because I found every little thing, measured every little joint angle, pushed on this. Oh, see, that's tender. I dig my elbow into their leg. Does that hurt? Oh, yep. See, you got a trigger point there. And
IT band syndrome.
Yeah, exactly. So we got to work on all these new things now, and they've got problems that they didn't even know they had, quote unquote problems. But if we can go the other way and say, okay, we've got a lot to work on here, but here's where we can start. We've got to start somewhere. Like, that's the biggest thing here. And people feel, what seems to be the case is they feel relieved that it can be simple to get going.
Right.
They understand, they're happy with just having a plan, because they are relatively logical and rational when you say, we can't fix everything all at once. It's not going to be an overnight fix. Like, they get those things, but you can't just leave it at that.
Right.
You say, here's where we're going to start, and are you cool with that? Here's our options. Here's what I recommend, and we'll go from there. And that's the first sell, is just organizing the thoughts around
right
where we start.
Right.
Do you ever talk about timelines with them?
Yeah, that's tough, man. That is really tough, because you set expectations when as soon as you even suggest an amount of time, like a numerical
It's already
value.
Because I'll cut it in half immediately. Like a doctor would be like, don't do anything for 9 months. I'm like, oh, so 4.5 because I'm not normal. That's for normal people.
And at that 9 month mark, you'd be like, you said 9 months.
I had a hernia surgery when I was younger, like the hip.
Yeah.
And the doctor's like, don't lift for at least 6 weeks. And I front squatted 200 kilos 3 days.
6 weeks? Oh.
3 days after the surgery.
And it stayed intact?
Yeah.
Oh, my God.
Yeah. The rest of my life was a mess.
Wouldn't recommend. I mean, there are, like, post-surgery, the tissues do have healing timelines. They don't, it's like a cut. It's like not healed.
Yeah.
But whatever. Good. I mean, you're a freak.
I wouldn't recommend that to anybody.
But
or
yeah,
you
it's
could be
like
like,
timelines are just like, fuck it, I'll just do this.
Rupture your
fine.
same patellar tendon again because you competed 9 months later. Because, again, he said 9 months.
Yeah, 9 months.
But I just
out there, yeah.
didn't do any PT because I was too busy.
Spinning high kicks to a wooden pole. Like,
I think you've got to give some people some reference, but there's some things like chronic issues, like patellofemoral pain, tendinopathies. They take a long time. You look in the literature and it'll be like natural process of natural history, 3 months to 3 years.
Wow.
And it's like you could fall into any one of those categories.
That's a good question. So when does something become acute to chronic?
You'll see definitions across the board, but generally, if it's lasting longer than 6 months, mostly we're talking in the literature, they will for sure define that as chronic, or 3 months sometimes even. Acute on chronic is a term, so something that's been going on for 6 months or longer, but this is an acute,
Right, like a
new
flare-up
exacerbation.
kind of thing.
Yeah, exactly. I give people those general ranges, and I actually say that, look, I've seen people, you could feel better next month. You could feel a lot better in a month. Like, that is possible. I've seen that happen. I've also seen this be a thing that people have to kind of manage off and on for a while. But I don't know, and I don't know where you're going to fall. There's no way for me to know that. So I don't make promises, because that has been me in the butt way too many times. But what I tell them is, we will know if you're making progress, because this is where we're going to track. We're going to track this, this, and this in your program. And I can't promise you. What I can say is the rate of your progression is always going to be slower than you want. I mean, just like PRs, like we don't set as many PRs as we want. So that's the same idea, but we're going to be able to track progress in that way. I do anticipate a month from now, we've got a little bit more of a handle on things. 2 months from now, same thing. And then at some point, there will be a point, hopefully what we want to get to, where maybe your thing is completely gone and you're 100% like it never happened. Maybe that's possible. But what is also success is you feel confident. You're not limited. You can do all the things that you want to do. It's just kind of there sometimes, but you feel confident in managing it, and you don't need me anymore.
So here's a question I think a lot of people would ask, and sort of, I think I know the answer, but I'm really curious. Like, I don't have any issues, right?
Are you talking about you?
At all.
You actually don't?
I'm just stating something.
I have trained.
This is like emotional,
no physical, emotional, psychological issues.
No flaws.
Perfect canvas, blank slate. Obviously, the question is, I'm a person who's got no pains, no issues now.
Right.
What can I do to prevent getting hurt? Warm ups, like if I warm up for
Rehab.
45 minutes, what is this, and like where's your stance on it?
No, it's a good question, and you had brought that up earlier. I wanted to circle back to that. Prevention is a thing, and I'll explain how it's a thing. And I'm not going to, not to be a nerd, but I come back to the literature, because it's just kind of an anchor for us. But you can measure prevention if you have a whole group. And you've already measured like average injury rates across this group, across multiple timelines.
Right.
You got an average, like there's about this many people get hurt, just in general, like a soccer team or something like that. You're gonna have this many ACLs or hamstring pulls or something like that. Then you implement an intervention, and you track them prospectively. So you track them in real time, and then you compare those outcomes to the prior baseline data that you have. And so you can say, per this number of population, we did or didn't prevent this many injuries. But that's on a group level, at the population level.
Right.
You have no way of knowing who's going to fall into what bucket individually. But that's the question that you guys are asking.
Right.
Is how do we prevent it individually? So if you do a bunch of prehab that you call prehab, it's prevention exercises because you call it that, right? And you put it in the beginning and the end of your program, so it must be preventing something that squatting doesn't. Yeah. Who's to say, and you don't get hurt? Who's to say you wouldn't have gotten hurt anyway?
Right.
Let's say you do get hurt. Was it because of those? Was it because of those injuries? Was it because of the training? Was it you would have gotten even more hurt? Right. So these are the questions that we can't answer, and I think the best, what we want to do is prepare people for their activities as best we can. My bias is from a performance perspective. I want you to be able to do it the way that you want to do it. Now, I think injury prevention is kind of bucketed within that, kind of intertwined in that, because the stressors of the activity is not going to be a surprise acutely to your body generally, if you're trained for it, if you're prepared for it.
It's probably less so significant in barbell sports because the activity and the training are the same, right? Exactly. So like doing squats is probably somewhat, preventative injuring your knees because they're getting stronger, right? The tendons and everything. So like, but like in like a team sport might be very different where, let's say you add squatting into some soccer players' routine, might have a significant impact on reducing injuries, right? But it's like, again, like you said, it's hard to tell on an individual level.
Yeah, and or make their legs tired so that they cut weird and tear their ACL.
So what
way to be a downer there. Way to really rain on the parade.
I shouldn't have said that.
It's true.
It's not going to happen.
So what does a successful relationship between clinician and coach look like if, assuming these are two different people?
I think it's, that's huge. I think it's complementary communication for number one. they actually know what the other person is doing, and they don't have to be. I think a clinician does not have to be an expert in strength and conditioning, and a strength and conditioning coach doesn't have to be a healthcare provider. But I think there's some benefit to having a little bit of knowledge or context kind of blending in both realms so that you can have a conversation. But if you have no clue, if you're both speaking this different languages and then you've got the athlete in the middle, it's just not a conducive relationship for the success of that person, because they're going to be hearing conflicting views.
That's where I guess I just get super frustrated. Like, I go on and on about this. I handle all of our cancellation interviews at the gym just because I always want to know, what. Oof. And I talk with,
hurt?
Yeah, it
hundreds
sucks.
a week.
I lose at least, I need 100 a week, and I lose at least 100 days off my life with each call. But it's like, I was talking with someone who had a back strain 2 weeks ago. So like, and it's very mild, muscular strain. So obviously it's like, I just want to be like, you're going to bounce back just fine, bud, but I was trying to be very kind about it. And yeah, I mean, the PT told him to take like 4 weeks off, and then we'll do a bunch of these exercises. And then this guy was just like too scared to lift weights ever again, and pretty much like quit because he wants to not lift and get hurt again. And so it's frustrating for me, but it's like, if I don't have a relationship with that clinician, I can't go and try and ask a clinician and be like, hey man, can you really help me out here and keep this client for me? Like, I can't do that. Like, what are as a gym owner or coach, like, what should you be saying, in those conversations?
I think treading lightly in the moment. So like that was tough because the decision had already been made. Mm-hmm. Yeah. And hopefully that person, time heals, not just physically, but also like the fear of things. Like, I wouldn't be surprised if that person comes back. Yeah. Because they're just freaking out right now, and they had a healthcare provider tell them something. Yeah, like they trust that is what they need to do. And I think so. You did asking questions, and a lot of times people will again talk themselves into getting back down to earth a little bit, and if there's any room there, I think you're trying to just see what they're willing to. What they're willing to handle, what compromises they're willing to make, and see if there can be a relationship gained between you and the provider.
Right.
On the provider side, it's great if they would reach out to you and be like, hey, I'm working with one of your members, and I just want you to know this is what we're working on. Yeah. I told them, this is a temporary thing, and definitely want them to keep doing the stuff that they want to do. Sometimes that doesn't always happen. Yeah. But I think if you can reach out and build that relationship, and actually that might actually help with the client as well. The client sees you as the coach going kind of the extra mile and trying to make that connection, because they want trust. They want to trust the people that they're working with. And it's just kind of the way it is. There's a hierarchy in people's minds that the healthcare provider, what they say is often just going to trump everything, because that just kind of makes sense. That's kind of how we're ingrained. The doctor of PT said that this is what it is. So as a coach, it's not staying in your lane, but it's being respectful of that, but seeing where there's room. So just kind of asking questions.
How does something like ClinicalAthlete fit into that equation, where you guys have like a massive network of providers that are also, a lot of them are also coaches, right?
Yeah.
And like, outside of the obvious, like, I can see where coaches might be hesitant to approach someone like you, or who is in that position of, they're a coach, they coach exactly like I do, and they're a PT. If I send my athlete there, he's going to poach him.
Yeah.
Or it's like, how do you with ClinicalAthlete, how does that fit in, and how can a coach utilize ClinicalAthlete?
Well, I'll tell you, if the PT's model is poaching clients, they don't tend to stay around that long.
Obviously,
you know what I mean? So
yeah.
I would like to think that had that been a ClinicalAthlete provider, you would have heard from that provider, and or that provider would have understood the demands of their sport, and you would have gotten much different. You would have actually had the conversation in that context, because it wouldn't have been an exit conversation. It would have been, maybe that client approaches one of you coaches at the gym and just like, hey, this is what my PT said. Like, they still want me to lift, but we're going to go off blocks or go to squat to pins or whatever, whatever the issue is. And so I think it is, first of all, the people in our network are biased towards athletes, and they're athletes themselves. That's kind of what our thing is, walk to walk. So they understand the athletic demands. They're not scared of them.
It's not the churn and burn PT model.
Right.
Exactly. And they're not they're not going to say squatting is bad for your knees because that PT has a squat session right after their shift, or you know what I mean. So they understand the demands, and they are also, even if they have a client list themselves, respectful of. I mean, part of our process that we train them on is defining your role, and if that athlete that you're going to work with has other stakeholders involved, you need to figure out where you fit.
Right.
And poaching clients is not part of our process
For sure.
of training, and that's just it. But it doesn't happen. If they've got a coach, I'll just take myself as an example of the clinician. I'm reaching out to the coach, or the coach has already reached out to me, or if the coach is hard to get to, I'm on the athlete constantly about show this to the coach. Let me know what you're doing still, because a lot of times they're still on a program on the back in the background, and I'm making as sure as possible that my program is complementary and not redundant or even conflicting with the stuff that they're already doing. So it's extra work. Like, it doesn't make it actually easier.
Yeah.
But it helps the outcomes, and it creates buy-in because the person doesn't feel so confused, like they're getting different
So like
pieces.
best case scenario for a coach who has an athlete that's hurt, they could reach out to like ClinicalAthlete and say, I think, or maybe they have that client like, hey, you should reach out to these guys. I think they can help you. That person would maybe schedule a call, and then like if you guys work together, it's a collaborative process where there's a little bit of communication between you and the coach and the athlete, and you know, because I imagine some people are like say a higher level where they're really like pushing for maybe qualifying for an event or something, and so there's a need to continue the process of training. Obviously, they buy into what's going on. They know they don't need to stop totally, but they also need to make sure that it's not like a prescriptive, like, here you go, do these 4 exercises twice a week and then call me in 6 months.
Exactly.
Right.
And the coach so what's helpful in that scenario too, if there's another coach, so defining your role is one thing, but defining done is equally as important. So if they're going to go back to the coach, if the expectation is I am going to go back to my old training program and my old coach, you're just in the interim right now, you have a specific role to help us get back on track. You have to keep your thumb on the pulse of defining when that threshold is going to be, like when you're going to hand the baton completely back off.
Right.
And oftentimes it's very arbitrary. Like, it's not, hey, I'm hitting PRs and my thing is completely gone now and I'm the best athlete that I've ever been still under my care. Like that's usually not the case. We define done as, we've got you back to the point now where you can head back to that direction.
Right.
And that's where, so I have to talk to the coach of like, at what point would you feel comfortable programming for this person again, knowing that they are still kind of dealing with this? It's not completely gone, but the momentum is very clear in the right direction. And we figure out a cutoff. And maybe it's like, if they could train squats 3 times a week at 80%, I would be very comfortable still managing like some of the load, but I just want them to be able to get back to like a normal schedule, handle the schedule, and then the dosing of progression the coach can handle. So we define whatever that is going to be.
Right.
And it's a lot of times arbitrary cutoffs, but it's not arbitrary to us because that's what we decided on.
Right.
So with ClinicalAthlete, like obviously, like I trust you and your company, and I've seen what you've done over the last decade. If I have a client come up to me and they're like, Zach, I've got this knee issue or whatever, and I recommend ClinicalAthlete, for the coach listening to this, the client then maybe goes, oh no, I got this guy through Kaiser I always see, or like this other guy I usually see. Well, like how should that conversation go if we want them to see our guy,
Yeah, I think, again, it's treading lightly. It's not, that guy's going to, no.
Yeah. No.
Unless it's an individual, like, straight up, you've already had experience, like, their name, and you're like, please don't.
Yeah.
I get that. But you explain, okay, cool, because you don't know anything about that person. Maybe the person at Kaiser is fantastic.
True.
I mean, honestly, like, it's where there's great PTs
That's a
out there.
big maybe.
I know, we're like
maybe.
name dropping. Something bad is going to happen.
Yeah, we're all going to get
defamation suit. Yeah.
Yeah, exactly.
Straight to you.
Oh, shit. Okay, but all you can do is explain what you hope they get out of a PT. So you can say, okay, cool. And like, based on however that goes, let me know, keep me updated on how that goes, what they say. Also, if you want, I've got options for you in terms of PTs who are power lifters and like no power lifters and trained power lifters themselves. So if that doesn't work out, or if you want a second opinion, let me know, and we can set that up too. So I think it's not like breaking down their wall and bursting their bubble right off the bat, but it's planting that seed that you can come back to, and then keeping your thumb on the pulse, like checking in with them to see what narratives are being explained and
during my cancellation call.
Yeah, because if you go in, you're going to go in like I get the skepticism, but if you lean into that too much, no matter what that PT says, you're going to be like, I don't know what they're talking about, and then it's kind of going to like the person can kind of sense that even when you think you're being open.
Yeah. And then they get offended, or whether they tell you or not, they get offended, and then they move on.
Because what if they're excited? Like they just came from that PT visit and actually had a good visit, and they're feeling good about it, and you kind of like poo-pooing on it a little bit.
So one of the questions I want to ask you was the role of pain in training. So like there's discomfort, there's injury, and everything in between. And from a coaching standpoint, again, with a lot of coaches listening here, the three of them that listen to our podcast, of course.
The rest are all clinicians.
How
we have 6 listeners on Clinical Athlete podcast.
Yes.
So.
Okay, cool. All right, we're almost there. We're half the way, and you've been doing that for 10 years or something like that. So good. What should the coach be looking for? What should the communication be around pain? What does the role of pain play in training? I just would love to hear your thoughts on this.
Yeah, another really good question. It's very gray too, and also kind of scary because there's like coaching education is like pain equals injury equals healthcare. Like stay within your scope, and like that's also true. But let's forget like the being scared of getting sued. And just kind of talk about like pain and as just a physiological experience and the person and you as a coach or a clinician, but you're just trying to manage this person. I think if you feel like it is outside of your scope and you feel uncomfortable with what they're telling you in terms of the experience, that's your first order of business of referring out is like your skill set and your comfort level with managing this. So just across the board, if the person's telling you that their foot's going numb, or they're like their leg is feeling like tingly or weak, or they're like have lost control of their bowel and bladder, then that's an emergency. So
it's a powerlifting meet.
Well, that's normal powerlifting meet.
That is true. Abnormal loss though, if it's a thing that happens regularly,
during the bench
that's
press.
Not normal. Yeah. Okay. That would be something. Interesting. But that's the first order of business is how comfortable are you managing that? And if you're not, like refer out and learn. And that's where you can actually like try to connect with the provider and learn a little bit, because coaches are probably a little bit more conservative than they need to be at the very first. But I feel like that's actually probably good. Like I'd rather you be overly conservative than like, it's fine. Pain doesn't matter.
Rub dirt on it, like, move forward.
Yeah.
I once had, there was a client once at our gym that squatted. And when they finished squatting, they left the gym. They walked to their car. They got in the car and they sent a message. And the message was, I injured myself on squats. And one of our coaches replied, how bad is it, like on a scale from 1 to 10, 10 being childbirth, like how bad was the pain?
Was this
What's that?
Yeah, how would you know? Is it a female client?
It's a female client,
okay.
Yeah. But sort of like childbirth has got to be probably one of the most painful things,
or
right?
kidney stone.
Yeah, so like a 10, right? That's a 10. And their response was, I don't want to be dramatic, but it was a 15. So
oh my God.
And they're driving.
They walked fine out of the gym and went home.
Right.
What do you do in that situation? I guess first off, what's a 15? Is that like being on fire while experiencing the entire
being torn in half
pain of all of humanity ever? But yeah, like what do you do in that case where it's like clearly this person it's like more of an emotional thing. It's not necessarily good at gauging, because like maybe there is an injury, maybe there's a problem, but it's so hard to understand because it's just like totally overwhelmed by the emotion of maybe it's just like I'm so frustrated that I'm hurt now I can't squat, and so like that adds to it. So
give them a little bit of time, I think.
Yeah.
Like give them a day.
So the next day it went up to an 18.
Call the ambulance. Call the ambulance.
It's a 19.
I think get an idea of what the next step is that they're okay with. Like would you be okay with their experience is their experience. If they say it's a 15, let it be a 15 in that moment. It's called it's an anchoring problem. So
right.
The 15 only is wrong if it if you're using those numbers to gauge progress over time,
Right.
It's like RPE. If somebody says, "Oh, that was a 10," blah 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 blah
Yeah,
blah,
do
they're
5
just
more
cranking
reps.
out.
Yeah.
Okay, it's a 10. It's not actually a 10 if I actually want to use RPE as something that gives me information. So we have
Right.
to fix your ability to gauge that.
Yeah.
But in the moment, don't fight with them about it. Just say,
I'm really sorry. I'll
Yeah.
be at your funeral.
yeah, exactly, and hang up.
What color do you want your casket?
I mean,
Yeah, laugh, actually.
Laugh.
but yeah,
Okay,
so
best
is it
practices.
just like, hey, let's say it was Max, like, dude, that sucks. Like, are you okay?
Right.
You know,
Yeah.
do you need help? Can I help you get home?
Right.
Can I
I
carry
mean,
you?
should you go to like ER? I'll take you to the ER. I mean, I don't know, but then checking in the next day. keeping
Yeah.
that
Yeah.
And the hospital
rapport.
thing, sometimes it's not a joke, but like if you sincerely ask, like, okay, I'm only asking this because you said it, and it's hard for me to gauge. I can't see
Yeah.
your face, but like, do we need to go to the hospital?
Right.
And 99
say
times out of
no.
100, they're like, no, it's nothing.
They
like
say
that.
no to a 15. That person is
I
psychotic.
don't think you know at 15.
Yeah,
they
exactly.
say
But
no
you
to
just
that.
in your mind, you're thinking that probably, but not. But in the moment, you at least got them to like bring it down
Yeah.
a little bit to reality. Not that reality is that they're not hurt, but reality of the severity of the situation.
Right.
And then check in with them. Ask them, hey, can I check in with you tomorrow? I know maybe you got a training session tomorrow. I understand if you don't want to come in, but I think potentially even having a conversation or seeing what you can do. But give it. I don't want to rush anything. So like, kind of meet them where they are. But it's a similar conversation to earlier. Is fine if there's any room for them to
Yeah.
not get locked into the.
In that
fear of it.
scenario, they were lucky enough to be totally healed by the Friday workout, so
about
it was
that?
fine.
How
Yeah,
about
that?
it
They
was
still-
shocking. The recovery, the
still with
turnaround was
us.
insane. Yeah, they're still with us.
So I'm really interested to see this. So in powerlifting, I'll speak to like my coaching experience, but I'm sure you've seen similar things in weightlifting. I'm sure you've seen this. Is like we coach a client. Let's say someone comes in the relatively beginner, and within like the first 18 to 24 months, we then experience maybe our first little nag.
yeah.
It's like the knee gets sore after a hard squat. Like they're actually really starting to push some good weights. They maybe started to sign up for the meet, and they have their first, we'll call it an injury. They have the 1st injury where back feels a little bit weird after training, or elbow after bench, whatever it is. Do you find that is there a data set, I guess, like after a certain point in either time length of training with some sort of marker of progress that just injuries are bound to happen in a sense?
Yeah, I wish I had a number off the top of my head. Like in the first year of somebody's training, what percentage of people will experience an injury? And defining injury, by the way, is also not like a consensus. I think the best answer to it is a situation in which you had to modify one or more training sessions, but like to what extent is an injury where I didn't modify anything, but it hurt like hell? Is that still an injury? So just even defining injury is difficult. But let's just say it's something that had caused you to have to modify training within the first year. I don't even want to guess because I would just be pulling something out, but a pretty high percentage is going to experience something, especially if they have a history already. Like that thing that they've already kind of been dealing with, maybe it starts to talk to them a little bit.
Because, well, one of the things, like, you never want to put, we call that, you termed the nocebo factor, right?
Well,
like,
it's a thing.
It's a thing. So nocebo. So like, you never want to put something in someone's head like, hey, by the way, you're going to sign up for my gym. Great. You just signed my 12-month contract. You're probably going to get hurt at some point. We're going to do our best to deal with it. But like
ready
in
for it.
reality, like I would say again, after a year and a half, 2 years of training, if someone's really making progress and stayed consistent, they'll experience they're strong enough to get hurt.
Yeah.
Like it's legit. Yeah. It's a legit thing. Should that be a discussion point as part of like some sort of client education? Should that just be we deal with it if it happens? Like what could a coach do?
I do get a little nervous about creating something in their mind when it wasn't an idea.
Yeah.
So I'm a little cautious of somebody who's like feeling like they're joining their gym and they're completely fine.
Part of your onboarding
It's probably
plan.
not something I'm bringing up right out off the gate. But if they have an injury history, I mean, I think that's a valid thing to talk about.
Yeah.
And just kind of get a gauge on like, oh, how you feel now? And
So let's actually do this. So I'd say tactical. So give me like your top 2 or 3 questions to ask to set expectations. If someone has a previous injury, now they're signing up with a new coach, what questions should the coach ask and note down to help them provide a better coaching experience?
Yeah. So what were the injuries? And all the details around it, like how it happened, how long ago was it, when was the last time you experienced it, if it's something that kind of comes on over and over time, like when was the last time you had this? It's like, oh, it was like 2 weeks ago. Or it's like, oh, no, this was like 6 years ago was the last time
When I was
this
bench
happened.
pressing in high school 40 years ago.
Yeah, exactly. So that gives you some reference in terms of what you actually would need to change, if anything, during the program. The nature of it, too, how it responds to certain training. So if this is somebody who's done this type of training before, they have actually a pretty good idea of what brings it on. They'll say, oh, yeah, when I squat, like every time I've squatted more than 3 times or like more than 2 times a week, or every time I try to squat 3 times a week or bench 4 times a week, this issue comes up. If they don't have any history of this, like say powerlifting, this is completely new to them, but they've had an issue in the past, it's an if game. You can say, okay, this is helpful for us. I don't think we necessarily need to make any wholesale changes or treat you any differently than we would otherwise. But if this starts to become an issue, there's a lot of things that we can do with the program. I just need you to let me know. I need you to talk to me about it. Because I will assume, that's what I tell my clients too, when they give me no feedback whatsoever.
Best.
It's probably because you're using True Coach.
Huge
Nice
mistake.
play.
Yeah.
So logic makes your athlete
It
give
actually
feedback like
does. It
Yeah.
gives you instant gratification because it tracks like RPs and tracks the data, and Max actually then sends you a thumbs up when you track your accessories. No, we've actually seen my client compliance rate has gone up. Lifters are now filling in their accessory work because they can see the data and the trends.
Oh, that's cool.
Because we track it.
No, that's cool. Gamify it a little bit.
Yeah.
Almost.
That's what we're trying to do. So hey, go
No,
on. But
that's
yeah,
good.
use Coach Logic for those of you listening.
And like, yeah, so it's if I hear nothing from you and I just see you coming in and out of the gym and training, I'm assuming things are feeling good.
Yeah.
So you have to let me know. But we don't need to be afraid of this. We know it's there. It's kind of in the background. We'll keep an eye on it. It may be something that we have to manage, because you said it. What is training for performance? It's literally pushing your physiological boundaries.
Mm-hmm. Right.
So when you have an injury, especially if it's locally to a joint or something, that physiological ceiling is maybe a little lower than the rest of the system. And so it's just something to kind of keep an eye on, but you frame it that way. And I think that lets them know that you hear them, that it's in our back pocket if we need to deal with it, but it's not something that precludes them from doing this. It's not something that plants the seed that's, oh, this is guaranteed to be an issue, but you have at least acknowledged it.
And so is there something about, like, so let's say someone comes in, they're a new powerlifter, but they've been training, strength training, and even maybe they had some sort of previous back injury.
Yeah.
It could be, it's a talking point. Let's go over it. What bothers you? And then potentially some education on, no worries. Like when we see things like this and if there ever are flare-ups, this is how we deal with it. And showing them like, hey, we have the education to deal with this. This is what we recommend. Are we allowed to say that? Like, should we even go there? Or just, cool, like, thanks for sharing this with me. We're going to we're going to do our best to keep you healthy and safe and move on.
If my opinion is that is, if it's within your skill set, it's within your scope, and it's absolutely a reasonable approach. If you want to add the caveat of, if it becomes something that we as coaches don't feel super comfortable managing, that we have some healthcare providers that we trust who understand powerlifting, and we'll have that conversation when need be. But we as coaches, just real quick, you guys deal with it. I mean,
We do. We're the first line of defense.
Everybody at coach
raise your
is
hand
injured.
if you've gone 2 weeks without a client coming up to you and saying, hey, this or that.
I don't
have any clients, but I deal with them all the time.
I don't talk to my clients more than once a month, so I'm not.
So once a month for you.
2 weeks is
Right.
I
too
haven't heard anything bad in the last 2 weeks. Seems fine. What from a like kind of practical standpoint? Let's say we're coaches and we want to try to integrate to some degree with ClinicalAthlete, even just from a perspective of like, hey, I've
jumped the gun, dude. I had no. Go on.
okay, like I have that sort of like, I know I'm gonna need it at some point, but like I find that like I'll have athletes and they'll get hurt, and it's like you just kind of don't know what to do sometimes. You're just like, okay, well, go to the doctor. And that feels like such a poor handoff. Like you're not really delivering anything useful. I will recommend like, reach out to Quinn Henoch or whatever. But like, is there a way or a channel for that to happen for people?
So this is a very mechanical, so I won't spend too much time on this, but we used to literally have a map
I remember
online,
that, yeah.
I remember seeing
ClinicalAthlete.com.
that,
It was
yeah.
the ClinicalAthlete directory.
It was the same as the NAMBLA map, right?
Oh, God. Don't do it.
Just kidding. Sorry.
It had everybody on there who was a clinical athlete provider.
Yeah.
So that public directory is not currently public right now because we revamped the entire process of how to get on the directory. Like we made it way harder, and we put people through this 4-month gauntlet to actually call themselves clinical athlete providers. So the directory is internal now.
Okay.
So but the process would be the same. Like you reach out to us, and we have a very vast network, and it's very likely that we have somebody in your area.
So people don't necessarily have the ability to look up a clinical athlete clinician on your site, like by map. I remember the map.
Correct.
But
Not at the moment, no.
Okay.
They get paired up if they enter
could find
like
it,
a lead
though.
form. They'll enter a form. Someone will reach out to them, pair them up with the local clinician.
Yeah, exactly. And honestly, we have many, depending on your desired activity, like whatever your niche is.
Yeah.
We also have probably several digital PTs who could help you, like in conjunction with your in-person coaching and gym. That would probably be as effective as you having to go to another clinic, to another place during your week. So you've got lots of options, and obviously that doesn't have to be local.
Right.
So I have a question. So one of the things that we talk about with Coach Logic a lot is like the data that we can track. Average weight, peak weight, volume, intensity, all this stuff.
Mm-hmm.
I don't know if you can answer this, but like, is there a data point or metric in that group that matters the most whether it be with injury prevention or a dial U-turn when it comes to getting someone back? Like what would you adjust, or what do you look at?
I think the principle is if you're trying to standardize something and actually monitor, you've got to just try to standardize the variables as best you can. So I differentiate between an embedded test and more of a formal or standardized test. So like in physical therapy, for example, we might hook somebody up in this dynamometer chair and like strap them in there and just have them kick their leg out against this pull gauge, and see how much force that can generate. But that's not their training. That's a standardized, formalized test that gives us a very specific information about that particular task and that particular system. And that's useful, but then it only transfers to our knowledge so much in terms of the overall training. So the embedded tests are the exercises themselves.
Right.
The squat, from a performance perspective, like we talked about, what is your estimated rep max going up based on the loads that you lift and your RPEs, or however you're measuring that. And so if you have some embedded tests that you can standardize to some degree, like they execute the movement in a similar fashion, rep to rep, that you can kind of say every couple of weeks, all right, let's hit that like 10 rep max or 8 rep max or 5 rep max on this particular movement that is relevant to what they have going on. That can be an embedded test. And within that, if pain is involved, then it can be what I'll define as tolerance. Let's try to define your symptoms. I will have them quantify meaning to symptoms. So I'll use the 0 to 10 scale as a way to gauge. So 10s, we're going to the hospital, 0 is no pain. But I qualify, has there been a scenario where you felt your symptoms, but they didn't change the way that you execute the task? And they say, yeah, like it's kind of there sometimes, but I can still move and put force into the ground the way I would normally. That's like a 3. I'll say, okay, cool. 3 is where we're okay with living. Now, has there been a level of discomfort that makes you change, either consciously or subconsciously? You do something wonky to try to avoid it. You shift. You can't put force into the bar like you normally would. They say, yeah, that's like a 6 or a 7. I say, that's where we don't want to live. But if you're 3, if you're able to handle more volume, more external load over time, staying at 3 or lower, that's progress.
Got you.
If same load, same volume, but hey, it was a 3 on week 1 and 2, but we're 4 or 6 weeks in now, and that doesn't hurt anymore. It only hurts when we go heavier.
Right.
And so you could pick 2 or 3 movements within their program and define tolerance that way.
Got you.
As an embedded test.
So from the perspective of like really what you're looking at, it sounds like is somebody gets hurt and their training now has to be reduced. So all of those variables as far as like the loads, the RPEs, all these things are going to come down. And you're basically looking for over time those variables, those metrics to come back to a point where, or maybe you can just see a trend of them moving upward back to where they were. And then you can say like definitively, hey, like you're at the same amount of pain you've been, but the RPEs of your sessions are higher, or your average weights are higher than they were, right at the onset of the injury, right?
Exactly.
Yeah.
And you can go down the line with their main, say their competition movements, down to the supplemental and the accessories too. So like we talk, and now injury prevention, it's like, okay, we already talked about how we can't actually, for the individual, we won't know, but if there's some accessory movements like isolation exercises that you think are relevant, like with your knee, it was like knee extensions for, stuff hamstring curl, so like isolate that area. Well, it could be the same idea. Like, okay, my 8 rep max on knee extension, where I'm standardizing the tempo and the positioning has gone up.
Yeah.
Well, it's not going to hurt. Yeah,
Right.
It's probably preventing injury more than it's not, if you're starting to see. But the way you track it is the same. You're just kind of picking what the method is.
So here's a question. Let's say someone has pain, and the pain is, 6 out of 7, 6, 7 out of 10, right? It's like not unbearable, but it's there. But all of those KPIs are moving upward. So they have the same amount of pain as they did before, but they're getting stronger and like maybe even they surpass old levels of strength or really close. Is there something you would do as far as like saying, hey, like you're hurting, but you're stronger than you've been?
You're describing my powerlifting journey.
Yeah,
no,
it's all of ours,
I would
right?
say-
6 to 7 is you're in pain. Like like
it hurts.
life sucks, but you take enough Advil
Yeah.
and icy hot to where you
So that
get through.
I know you're joking, but that's
true.
a scenario that's not sustainable.
It
So if
isn't,
that,
yeah.
Wait,
but
what?
so I think actually you're describing two different scenarios though, because that's the cycle of, all right, we're just doing enough to mask it, but it's not sustainable.
Right.
At some point, the ibuprofen's going to wear off, and you switch to Aleve because that will help in the short term. It's the same cycle.
Yeah.
But what you're describing is they're at that 3 and down,
Yeah.
but it's not. They've hit kind of a plateau, like it's staying there, but it's not.
Pain
getting
hasn't
worse.
changed, but strength is moving up.
And they're like, otherwise their performance is exactly how they would want it, or at least is trending that way. It starts with a combo. Like I'll ask them literally, "Are you like this is where we are, and this is what I'm seeing. Mm-hmm. How are you feeling with this scenario? Like, what if this was your norm?" Some people are like, I'm actually okay with that.
Yeah.
Because I have felt this, like I'm good as long as I can train the way I want. I'm okay with feeling it like this every so often. Some people are not okay
Right.
with that, and
they'll never be the best.
That's true.
Nobody
Never
will
make
ever
your dad
remember their
proud.
name. What, yeah.
So
No
true.
one remember your name.
Yeah. Yep.
Now, and so then I have a conversation like, okay, we can keep going. And it's a real talk conversation. Like, I don't know how much more change is going to come. It's been 6 months and we've made great progress in your performance. We've got this thing under control. I don't know that it'll be another 6 months and that this will be to 0 or it'll be the same. I don't know that. So you can keep working with me, trying to bring you as much value as possible here, and here. Or you can kind of go off on your own with coach and I'll be here in your back pocket if you need me, that type of thing. That sounds kind of weird. I won't be in your back pocket or that person's.
It's okay. You can be
maybe
in
I
the
am.
Yeah, you shrink down.
I'm in your closet. I'll be in your closet.
Well, you're still in your closet.
He's
so.
in the closet. He's coming out this afternoon.
One of the last things I want to ask you was the role of movement assessments.
Yeah.
I think that it's kind of can be buzzy. I know some coaches do them, some coaches don't. Like, what do you feel like the role of movement assessments play in, let's say, the role of the coach and then the clinician into actually doing something productive?
Yeah, it's like, okay, so movement assessment, like you come in, you're a power lifter. I know you squat hundreds of pounds, squat, bench, dead, or whatever, kilos, whatever, but we're not going to do that stuff in here because this is a healthcare thing where I'm going to watch you move. And so I'm going to put you through some of these unloaded or very lightly loaded movements that may or may not be your competition lifts. And then that's going to give me some information. And I think that maybe that does give you some information. And it's not useful, but I think as the coach and clinician, these unloaded movement screens where you're just watching somebody that is not putting themselves under the same stressors as they're training, you have to try to really tie back into also bearing in mind that they're going to go and bust their butt in the gym for 2 hours right after you just had them do this.
Yeah.
Or before.
Heels elevated overhead squat, or whatever it is, or leg lift or whatever, is that stressor going to just supersede everything that you just saw?
Right.
People also move differently under load. So what your squat looks like with no load is not necessarily what your squat looks like with 400 pounds on your back. And so for me, the magic is not on day one, to be honest. Like a movement screen, the magic to me is seeing how they are responding to load over time. And their history gives me as much or more information than me having them go through these lightly loaded movements without having them at least approach the same stressor in the moment. Because I think what is useful if you've got the time is I'll have people come in and actually work up to some squatting or deadlifting,
Right.
Approaching the loads that are giving them problems so that I can actually see that. Because that's a movement screen that's specific to their problem, not their single leg hinge.
Yeah.
And again, people get
flustered.
emotional about
Yeah,
this
yeah.
stuff, but
Yeah.
it can have a place. Just be honest about the information that it's telling you, and don't forego what they're actually experiencing and the stressors that they're actually experiencing it in, and seeing that as kind of separate in your mind, be it a coach or a clinician.
Here's a couple of questions for you. There's, in the world of Instagram PTs and Instagram influencers with all kinds of advice, and
Especially the guy with the hammer that does
the hammer guy.
Yeah.
There's the higher education guy. But like the whole world of like, it's nocebo. It's a lot of like, if this then that,
Yeah.
and absolutes, and just like bad posture equals injury and pain. Is there any one or two like major just like garbage information things out there that just won't die, that you just can't, that you would like wish would die?
Static posture is probably one of them.
Yeah.
Like laying, especially like passive posture, like laying on your back and, you know, checking leg length or something like that. Like you can change leg length in 2 seconds.
Yeah.
And then you can also change it back in 2 seconds too. They can lay differently. Like it's just so unreliable. Posture is the same thing. Like you're measuring dynamic millimeters that
Right.
you're never in the same position more than once. So it's not that posture doesn't matter. Posture is amoral. It's just position.
Right.
So we're in posture all the time based on our tasks. Like we need certain postures, and then other postures are maybe not as mechanically advantageous to a certain task or whatever. But to deem something right or wrong, it just doesn't make any sense. It goes back to our thing of creating problems. So I think find the bottlenecks, the true bottlenecks for that person. So going back to the movement screen, if somebody literally doesn't have the joint range of motion, if they want to squat past 90 degrees,
And they can't.
and they physically, their hip does not do that.
Yeah.
That's a thing.
It is.
It's
a thing.
Yeah, I mean, maybe they have an ankle that's fused.
Yeah.
Have you ever tried to squat in like a boot? It's very difficult. So like that may be a bony thing that's permanent, but that's like not usually what we're talking about. What
Right.
we're usually talking about is people can't access the range of motion that they actually have. When you lay them on the table, you move their hip. Maybe they're not like Gumby or a gymnast, but their hip goes to 90. It goes past 90.
Like they have passive range of motion.
They have
but
the range of motion, but
when there's
they,
a load, something changes.
right, or even just gravity, something changes. And so you're try to identify what the actual bottleneck is. If the bottleneck or their issue, either be it a movement quirk or symptoms, only happens at a certain load or volume threshold, then what you're doing there is not yet telling you that information. And so that's not the bottleneck.
Right.
Squatting is not their bottleneck. It's their load tolerance. So
Right.
find that.
And it's not so inherent that posture is a good or there is no such thing as good or bad posture. There's the posture that you're in, which is the position your body's assumed, right? And then like during an exercise or a movement, you assume a posture to execute that.
Right.
But having posture of in a certain position may or may not be advantageous, but it isn't necessarily causing pain.
Well, it like if you sit, so if I sat for 8 hours a day, every day, it might start to feel a little achy and uncomfortable. But if I stood
For
in the
8 hours.
same spot
Yeah.
for 8 hours a day,
Right.
every day, it would probably feel a little uncomfortable.
Yeah.
So like movement is the thing. It's kind of why we move around in our sleep a little bit. So again, it's not the one posture, because we could play that game all day. Just like muscle, the psoas is a problem on these 10 Instagram sites, and then you look, and actually the psoas is the magic cure to fix your back pain on this.
Yeah.
It's like
Yeah.
across the line for each muscle. So posture is kind of the same thing. It's like good or bad depending on who you ask.
Right.
So for coaches, just to sort of wrap us up, so for coaches like listening, what would be good resources of information, including Clinical Athlete for them, or even other people as well? And then if they did want to, do you guys do furthering education where they can go and learn from you or from some of your clinicians so that they can get better at some of this stuff?
Yeah. I mean, we just did an in-person course where it's always a mixed group of coaches and clinicians.
And I went. We hosted one of your guys with John Flagg. You were there.
Exactly.
Yep.
Yeah. So we just did that. It was a super total though. So we did weightlifting and powerlifting.
Oh, nice.
4 people. Oh, they didn't just do super total. They were weightlifting.
Everybody had to do both. And so it was like weightlifting was on day one, and so I had some good laughs with the powerlifters, but and then the weightlifters, could barely lift 60
Couldn't
kilos
even
on a
deadlift.
powerlifting day. Yeah. So they can do those, but we don't. We do have coaches in our online mentorship. I would say it's 90% clinicians, but it's open to coaches, and I love having coaches in there.
Yeah.
Because I love my rehab and PT brethren and sisters, but sometimes we overthink this shit out of things, and we're looking for like the most complicated, complex answer and solution, because that's kind of what we trained our brains to do.
Right.
And it's just nice to have a different perspective, almost from just kind of a performance perspective to start. So we love having coaches and trainers into our program. Jump on our email list, because we're always kind of putting out in blog or short video form.
Do I get some sort of lead magnet, like a 2-week guide to?
We give out free. Actually, we give out free. We have like 5 of my free lectures that we give out on autoregulation, hypertrophy, strength.
Anything
rehab.
to increase height? Like I'm trying to get taller.
I wish.
Yeah. Do those pills at the gas station work?
We'll see.
You're a doctor.
You're a
right?
doctor.
Ask me in about 3 months.
3 months.
And yeah, so I think that. So Clinical Athlete, obviously, Barbell Medicine is a great resource. E3 Rehab.
I've heard of them.
E3, they have a great YouTube channel.
Nice.
I would say it's like the complementary YouTube channel for, maybe what we're talking about, all the stuff we're talking about here, compared to maybe some of the more nocebic and good versus bad, that type of thing.
Do you have any quick like heuristic for somebody to try and parse out good versus like useful information versus like potentially just bad?
Yeah. Ooh, heuristic.
Yeah.
What a word.
I'm gonna look that
Rule
word
of
up.
thumb. I like to try
It's
to.
my word of the day today.
Yeah.
I had to get it in somewhere.
I think when somebody speaks in absolutes, red flag ish.
I said that about coaching earlier.
Yeah. I mean, it's the same. There's too much nuance to almost every scenario on the internet without any context whatsoever to be able to say something is right or something is wrong, good, bad. I think and along that same lines, like the list of the 5 best exercises for knee pain or the 5 best squat variations, or what I mean? Like, okay, it's fine. Like, I'll give us ideas for like exercise variations. That's what I like. I'm like, oh, I like that exercise actually, but I apply it in my mind to how I would apply it in context. It's not like memorizing. So those aren't bad per se, but as the consumer of that information, these are not lists that you have to memorize. Take each exercise that's recommended as a method and then ask yourself, okay, in what scenarios would I implement this and where would it not be useful, even though it's titled by your favorite IG person of the 5 best this.
Well, it's good for the algorithm.
It's
the
great.
list.
Yeah.
It's great for the
We've
algorithm.
been doing a lot of lists.
We
love
Big
a good
red
list.
X, so another post
Yeah.
like, movement positions over here with the green check mark.
Yeah. Oh,
positions
yes.
over
And
here
then
with
the
red X.
anatomical
The body.
the anatomical like movement, and it's like this is like terrible skeleton squatting down. X wrong, bad posture.
There's one page that had like an exploding disc. It was like a nuclear, like a mushroom cloud out of their back.
Yeah.
So
Is
that
your
was
back
helpful.
fart?
And it got like 1 million views because they had a very large reach. So it's,
If you just
So many
sold your
people.
soul a little bit, you could increase your
I would be
Instagram
rich.
reach.
I would be rich.
Yeah.
Well, hey, I really appreciate you coming on.
Yeah.
You're a wealth of knowledge.
Oh, yeah.
I forget, because we don't talk often enough, but maybe we should. And yeah, I hope for those people listening to this, you guys got actionable items to really help you improve training, prevention, how to deal with those athlete conversations, because that's like what we deal with a lot is just talking those athletes off their ledge and knowing when to pass the baton on to the provider and find a provider you trust. So check out Quinn at ClinicalAthlete. Check him out on IG. I think he also has an OnlyFans. No,
in the works.
In the works.
In the
Okay,
works,
got
okay.
you.
Yeah.
But thank
This
you.
is my studio. You guys didn't know.
Fully closed. It's fully closed.
This is actually going on the
Yeah.
on the channel. I appreciate you guys. This was a lot of fun.
Yeah.
Cool,
Yeah.
man.
Thanks for coming.
Yeah.
Oh yeah.